Well, thank you for being with me here today. I am Dr. Laurel Barr. I am the chair of the Early Career Physicians Section. I'm here with the chair of the Dual Physicians Section today, Vinay Mikkilineni. Thank you for being with me here today. We've got a lot of great things to talk about.
Sounds good. Thanks for having me.
The mission of your section is to provide a home for dual training. I am in family predominantly, but also peds and anesthesia and aerospace to share information, network, provide key information to medical students in dual training.
That sounds about right. Yeah.
Anything to add?
We have 21 programs. 13 are EM/IM. There's 4 EM peds, 3 EM FM, and 1 EM aerospace and 1 EM anesthesia. It's a place for people who are dual trained, whether it be in those specialties or others, but in primary specialties. So this is not including fellowship, and an area for them to kind of connect and discuss things that oftentimes cross different departments.
Yeah, absolutely. I'd never done anything outside of my specialty in the emergency department. In fact, I'm actually married to an IM physician, so I feel like this is the schizophrenia of both of us. My differential for seizures is a little bit different from his differential. Mine is like, is it a seizure? Is it drugs? Is it alcohol? Oh, it is a seizure. Can they go home? Can they come in? And his is like metabolic problems and I don't even know what else because I don't have that differential. So I'm sure you could expand on that. So there's a whole lot of different things that we treat a little bit differently. So it's great to have that extra training.
Yeah, I mean, for sure. Actually, just the other day, I was in the ER overnight, and there's the dreaded hyponatremia case. And yeah, it was interesting because like the IM side of me was like, okay, I can order a few things and then actually figure out what it is. If it's just hypovolemic, maybe I can get the patient out of here. Versus if it's something else, then I should probably bring him in.
Oh, I love that. I'm like, okay, they're hyponatremic. I get to admit them. Should I order the urine studies? I think I know what they are. They never come back and I never interpret them. All right, well, talk to me about some of the things that your section is doing. There's a whole bunch of different things, residency fairs, conferences.
The biggest big brackets are kind of geared towards medical students in terms of what as they come up, because they oftentimes don't hear about dual training. You go through all of these and people are like, oh, you have to pick one, but then you're like, oh, but I can actually do both. And then med student advisors often might create a persona that, oh no, but you end up actually practicing one. That's not necessarily true. My own practice is about 1/3 EM, 1/3 IM, and 1/3 non-clinical. So you can kind of actually build your practice to whatever you like and what your interests are. So that's a component is geared towards the medical students. And then the second is obviously our faculty and creating a network for them. So that way we can help collaborate and work together in terms of kind of providing challenges. For example, one comes to when you're getting hired, how do you navigate that dual department component? How do you address issues that cross like boarding? It's not just a let's discharge faster. It's maybe we need to try to address the post-acute care component and address legal changes about Medicare. So I think there's these spans that you see with a bigger systemic view that helps.
Yeah, excellent. And especially as boarding continues, there's so many things that I'm like, I mean, I can stabilize and I've stabilized and I don't know, they can probably be discharged, but we still haven't gotten them follow up. And I don't know, I admitted them 24 hours ago. What do you want me to do?
Yeah.
I feel like sometimes my brain just stops and I'm like, well, that's where I'm done. And
Yeah.
then you can keep going, which honestly should make you very valuable in the job search coming up.
It often does. It's just whenever we have to try to create that dual hired role, which makes it sometimes harder. It's like, hey, I actually don't want to be full-time ER. Then people get turned off a little bit. But for me personally, the nice thing is I'm also a nocturnist, which then everyone loves.
Everybody does love that. I just came off nights. I want you to work my nights.
Yeah, I just worked all nights and I'm like, I loved it. It was the best thing.
And you can do 7 in a row, and I peter out at 3 to 4. No, that's great though, because the more I talk about, wellness and burnout and trying to carve your niche, I mean, this sounds like a great way to be dual trained because if I want to do something else, I have to go back to residency. Well, you've already got that training, so you get a little burned out in one area, you can go to the other area and get burned out in that area and then come on back. Oh,
Yeah, and you can shift that career too, where if you're like, oh, I've done too much of this thing, let me just shift my clinical time in a different direction. And I've definitely done that. And then it's the same concept that like for our IM colleagues, a lot of them when they go to do palm critical care, they are deciding between palm plus crit care or just crit care by itself. And they're like, but if I get older and want to do clinic instead, they have that option with the palm crit care. And so sometimes that argument is made, but like I think the dual training helps in that same scenario where you have things you can shift into should you want to in your career.
it's almost like you can't choose though, right? Because you want to do the clinic and you want to round and you want to see the high acuity, undifferentiated patient. So you can
Well,
do those things.
yeah, that's fair. We can do all of it, but I think we definitely see that our residents gravitate towards inpatient or outpatient sometimes. So we see like a lot of people will mix like outpatient with emergency or inpatient with emergency. Like, so I work predominantly, I don't do any outpatient. I do only inpatient and hospitalists and ER.
Well, and certainly IM, you can do inpatient or outpatient, and most people
Mhm.
nowadays either do one. It
Yeah.
seems like they're both a full-time job.
Yeah.
I mean, I feel like though you get every perspective, you also get everybody's problems though, right? Because you have to some of your advocacy issues are like, on re insurance reimbursement. And I feel like that's the one good part of the EM job is I get to just bypass all that. We might not get paid for it because we bypass it all, but at least I don't have to spend hours on the phone just to get a CT approved.
It's the same on the inpatient side. You actually don't like we don't have to like order anything for diagnostics. Like we don't have to get anything approved. It's whenever we start transitioning to that outpatient space. So it's like the post-acute care we sometimes have to argue for, or like in the outpatient space, hey, this patient needs a medication. Um, but agreed in that like we often don't think about it in the ER. Upstairs, a lot of people don't think about it at all, and I see that from residents like education perspective. But then when you talk about some of these bigger issues like boarding or decreasing like our salary upkeep with inflation, things like that. I'm not arguing that necessarily that our salaries are under by any means, but I think it just helps in terms of knowing and seeing that bigger picture.
Well, and you can look across the spaces too and see the difference. And then you also have an idea of, what the effort is behind it and what the schedule is and
Mhm.
and maybe a little bit more insight onto, well, if this is going to be higher paid, then I'm just going to do that, or I'd do that for lower pay or more than I do, who just says, I don't know, pay me. I see patients, just pay me. I don't know.
Yeah. And some of it too is like obviously like IM, for example, I do IM EM, but we have our IMF EMFM colleagues and EM peds. And obviously sometimes usually one specialty pays more or less than the other. Um, but I think then you can consciously make that choice of like you were talking about that career choice of like, hey, I don't want this higher burnout area. I might accept a little bit lower pay and take this um, lower burnout area and vary my career and have more longevity.
Which ultimately is better for everyone and your pocketbook, no matter what you get paid for it.
Yeah, exactly.
Tell me about this upcoming conference you have. I hear it's tomorrow, so by the time we get this out, then you'll have a lot of great things to say about it. But I love this section because you're an ACEP within an ACEP. So you've got your own training that we don't have, and you've got your own conference. So what's going on?
Yeah, this conference is idea that was from a long time ago before me, from chairs well before me. And the idea was where can we create a space that we talk about some of these things that are crossing departments? Um, and then we can bounce off of ideas off of each other and to kind of emerge some of those ideas into fruition and bring them more to light. Um, and one of the highlights, I think, from last year's conference was like one of the projects from Boston where they were, and VCU, they were doing primary care education for EM residents. And nothing that's extensive, but it's just like, hey, what hypertension meds should you be starting? What diabetes meds should you be starting? And just like a very basic, like first line. and that's it. Or like, but that then translates to a better transition of care into that next phase for the patient. The worst thing you want is like as a patient to have like 3 appointments and only one thing get done. So you might as well start that care when you can, especially when you start talking about our underserved patients whose primary access to care is the ER, or migrant health, where it is they're coming to the ER because that's where they can go. Um, and learning to not be afraid of medications you never necessarily order. And but one of our residents, for example, is now interested in primary care as a long-term career. So we were like, hey, why don't you bring this to our institution in terms of the education component, and then we can run with this and see how it goes.
Yeah, sounds very applicable to all EM. Don't give me a long 1 hour lecture on antihypertensives. Just
No,
tell me when the person comes in nervous and I want to actually start one, which one I should start.
exactly.
Let's see. It was the I don't remember what the guidelines were, but it was version 9 that I was taught way back in residency. So I'm pretty sure that's up to date right now. Or that's not up to date right now. So that and the conference was new last year. So it's an
Yeah.
entirely separate conference outside of ACEP Scientific Assembly, like really this section on their own doing huge things. And it's a brand new thing. So it will be the second one this year. So it's a great opportunity. I mean, it sounds like you need people for topics for presentations and a whole lot of them. So a great way to get involved, or a great way to just dip your feet in and see if you want to go to that. I'm hoping, so I went to an IM conference with my husband, and I discovered that EM was the butt of every joke. It was especially in the cardiology lectures. It was like, oh, what type of heart failure is this? Oh, it's the one that EM admits. Oh, they have chest pain, call us. And at some point I had to declare myself in the small groups and say, all right, stop that. So I imagine it's a good way to go get training and not be the butt of every joke.
Yeah, that's fair.
I mean, I kind of wasn't surprised after the fact that we'd be the butt of every IM joke. We give them all their business, so we are the pains in their butts.
Yeah, and it's interesting because I think like every specialty conference you probably go to, there's probably another specialty that they predominantly will uh, make fun of, and it's usually the specialty that's giving them more work.
So us is what you're
Yeah, yeah. Um, but yeah, and I think like it's like this year's conference too is discussions around the expanding care in EM. So some of the things that we were just discussing, and like tomorrow we have Dr. Otero, Dr. Raju, and Dr. Likens all talking about let's see here. I have managing the agitated patient across care settings, heal at home, redefining home care delivery. And then ED utilization and disease burden for migrant patients. So I think these are topics that are very applicable to EM, but then expand into let's bring in the outside aspects to it.
Yeah, almost spill into EM
Mhm.
from their outside aspects. So say I'm a medical student who wants to go into dual training. There's a residency fair that I can go to.
There is. This has been going on for about 4 or 5 years now, I would say. Actually, a little longer. And it started, it's every May now that we do it. And it we bring in all of the residencies that are dual trained, including EM, IM, EM family, EM peds, EM anesthesia, and EM aerospace. And so the program directors or some leadership from the program will be there as well as residents, and you can hear their kind of spiel or talk to them directly of what that career looks like. And usually it's a pretty simple model where you have two small panels just talking about combined training. And then subsequently, the rest of the time is just breakout rooms for you to go and chat and talk to all the residencies that you want to and just learn what dual training is like. I think we see a whole gambit of people who are M1s all the way up to M4s, just exploring the field and being like, what can I do after I graduate? Because I always tell this to medical students too, is you shouldn't look at what residents do because residency is just a very short period of your career. You should see what attendings are doing and what their careers look like, and that's what 30 to 40 years of your career is going to be. So that's where I think it's important to gain that perspective of what that career looks like.
Yeah, absolutely. That's a great point. When I was a student, it was like which residency, which residency,
Mhm.
which residency. And there was a goal of attending hood, but 3 years of your life to 5 years to 7 years is a whole lot of time when you're in your 20s.
Mhm. I agree. Yeah.
It's hard to see past that sometimes. You just
Yeah.
expect everything else to work out, but then the reality hits and it's nice to have that training and that flexibility and really make it what you want.
I think that's always the debate too, especially when you look at like 4 year versus 5 years for us. If you're looking at a 4 year EM program versus 5 years, it's one more year and you have the ability to kind of vary your career a lot more.
Yeah. Well, then that's a good segue into your advocacy priorities. So you mentioned 4 year versus 5 year and getting that dual IM trained, because one of your priorities is really to advocate for dual trained patients on the ACGME, which in EM training, there's been some changes which have been discussed previously.
Yeah, that's fair. That's an easy way or a nice way to put it. I think the big thing, especially, is if you look at the ACGME model, it's supposed to be where the ACGME core represents whatever specialty they are presiding over. And so in the past, all combined programs, and there are actually 45, I think, combined programs, not just the EM ones, but there's like you got to take away med peds because they actually act a little separately, but like all of the other ones, there's like a PM&R peds and radiology and nuclear. And so there's all these combined programs that exist. And one of the questions that we had was when we were going, because this is the first year that combined programs are now accredited by themselves. Previously, they were accredited under the payer and bodies. Um, and so now that they're accredited, when that was the case, for example, EM accrediting body and the IM accrediting body would accredit us. And so that means we had representation. So we knew that there were people on the accrediting bodies that knew each side. Currently now we all, for example, EM, IM, EM, FM, and EM PEDS all fall under the EM accrediting body. So that means actually, when I look at it, there is no one who is pediatric trained. There's the PEDS fellowship trained people, but not pediatric trained, so they don't know the outpatient PEDS side of anything. There's no one FM trained and no one IM trained sitting on the accrediting body that represents us. Um, and there's similarly EM anesthesia falls under anesthesia, so there's no one EM that actually is on that accrediting that dual combined program. And then there's EM aerospace, which sits under it's I think preventative medicine. So there's no one EM trained that actually accredits that. And then similarly, this counts for other combined programs in the country as well that are not just EM ones. So some of the advocacy work there is saying, hey, all these combined programs are now accredited on their own. We should probably have people who actually know both sides on the um, council or that represents or creates the requirements for these programs.
Yeah, certainly. I mean, when you talk about how many dual programs they are, it's a big challenge to kind of add those things. But as you get this training, very important that you get good training in both. Seems like a very good advocacy priority.
Yeah.
And also someone looking in saying, yeah, why not? Why doesn't that happen? Like it's a common sense, but it's probably strategically very difficult. So
Yeah, and it's all because of a change that happened this like 2 years ago.
mm,
Before, all these combined programs sat under both boards, but now everyone sits under one or the other board. So then it creates this issue where it's not actually fully represented by the board.
Right. So it has been represented both sides, but then you probably had to deal with both sides and get
Mhm.
certain approvals coordinated. So probably
Exactly.
simplified, but also need to have the correct training. And every new change comes with other things that you don't think about before. So
Exactly.
correcting those and advocating for them is really what we do.
Yeah. Yeah.
Who knew that people would get hypertensive and need their medication switched? I don't know. Now we got to figure out how to do that. Well, awesome, great thing to advocate for, and definitely, within your section. Um, Another advocacy priority is myth busting. And I wanted to play the Mythbuster theme song on here, but I don't think I can. So
That's fair.
I don't pay for YouTube, so I think it'd just be like a Viagra commercial if I tried to bring it up. But I'd like to start with some myths that I'm going to give you. All
All
right.
right.
So, how do you hide a dollar from an EM physician?
Well, that's a good question. Um, I would think put
Put
it
it in
outside
the
the
chart.
ER.
You put it in the chart.
Oh, all
How
right.
do you hide a dollar from an IM physician?
Um, put it in the ER.
You put it under the dressings.
That's fair.
How do you hide a dollar from a peds physician?
I'd say give it to the parents.
That's a good one. They don't know what one looks like. They never see it. I just had to do that. So, a favorite of mine, since my husband is also IM trained, so I get to make fun of him for that. Um, so how do you hide it? Speaking of, making fun of other specialties, at least that aren't ours, so that I don't get myself in trouble. How do you hide a dollar from an ortho physician?
Put it next to the stethoscope.
Ooh, that one could be good too. You put it on the EKG, which is also a double-blind study to ortho physicians read
Mm.
EKG. All right, so I've made up my own myths. What other misconceptions are there about dual training that you need to get across so that we can get the best physicians into this specialty?
Yeah, I think the oldest one is that going into a dual training specialty is like it's often what people say is like the $500,000 mistake. You're losing out on 2 years of salary or 1 year, depending on which combined training you're going into. Which isn't necessarily true because again, you're talking about the longevity of your career rather than the 1 or 2 years that we were just talking about in terms of when you're looking at beyond medical school. Um, that's one component. I think another one is that this one came up at council, I believe, that EMIM or EMFM people aren't as well critically care trained um, than like the EM side, which I don't know if that's necessarily true because, example, our EMIM residents, for example, do about 6 to 7 months of critical care training during their time in the ICU versus our EM categoricals do 4. So oftentimes it's usually a lot more of critical care training. And I think that stands true for some of our EM peds, for example, they have more time in the PICU. Um, Obviously our EM anesthesia as well, they're probably spending a lot more time with intubated patients. So I think, yeah, some of these myths in terms of what knowledge do they actually have, do the combined providers actually have versus um, career mistakes that it might be or things like that oftentimes are the big myths.
Yeah, doesn't sound like a mistake, but I knew EM fellowship as the $1 million mistake. So the stakes must be lower if you know it as the $500,000 mistake. So that should tell you something about dual training.
Either that or salaries have gone up from when that myth was created.
You know what? Very much could have. Outpatient is the only one that's actually increasing, but probably because it's been so deficient for so long.
Yeah, yeah. That's an appropriate thing, I would say.
Yeah. Well,
Uh,
if they don't pay the outpatient, then they just come to the ED anyway. So it's
yeah,
like,
yeah. Some of my own work is actually looking at outcome data based on specialty versus primary care and seeing where we can have the biggest impact in terms of workforce allocation as a nation.
that sounds like a very good research project. I'd love to see the results of that. All right. Well, ways to get involved. So, these videos are hopefully for people who are looking to go into the dual training section and the specialty. Um, It sounds like you've got a conference that is a great way to kind of start and network and meet people and even join and present topics. What other ways can we get involved in your section?
Yeah, I think the biggest and probably the most, or the thing that we're building the biggest, most of right now is a resource page on our dual training site. Um, and the dual training site currently it just has a FAQ for interested medical students, but we want more resources there and topics of knowledge that combined providers have learned over the years in terms of whether it's how to get hired across two departments. How do you navigate that? Um, and resources that oftentimes go towards things like observation, because we do a lot of observation medicine, often the dual trained providers, or how do you subsequently address administrative aspects in terms of dual training. Here's resources of projects that cross departments that you can contribute in. One of our med students who's interested is actually looking to work with us to create a mentor program. So how can we plug med students who don't have dual training, because there's only, 21 EM dual training programs. And that's not, so there's lots of the parts of the country where med students have no exposure to this. So how can we create that mentor program where then, hey, I'm interested in this. Can I reach out to someone and talk to them about it?
Yeah, awesome opportunity both to be mentored as a medical student and then maybe once you're further in your career, get involved as a mentor, which is incredibly fulfilling.
Yeah.
All right, let's end on what advice do you have students going into dual training or really just dual trained early in your career looking to get involved in the section?
Help build our resource page and help us both in the residency fair, the conference, come talk. Part of this is getting that exposure for dual training, both out into the world and the ACEP community, but then as well, just show up. Once you show up, you'll realize that this is what you want to do. That's how I started. I just was like, oh, this seems interesting. And then I learned about it. And then I was like, this is exactly what I want to
Sounds exactly how you want to go about it.
do.
I love it. So dual training section, open to anybody who's dual trained, open to medical students who are looking to be dual trained. They're a little mini ACEP within ACEP within their own little specialties. Sorry, little specialties within your own broad specialties. Um, and really come get involved, come educate people like me how to treat hyponatremia. All right. Well, thank you
Sounds
so
good.
much. Thanks for taking the time to do this. I really appreciate it.
Thanks. Have a good one.